Pipe it up.
Hold on, my brother, don't give up.
Hold on, my sister.
Hold on, my sister, just look up.
There's a master plan.
There is a master plan in store for you. If you just make it through,
God,
God's gonna really blow your mind.
He's gonna make
He's gonna make it worth your time.
all the trouble.
Good evening, everyone. Welcome again to Mosaic Voices in the Community. Our guest tonight is Dr. Danielle Motley Jennings. Please send up some hearts to welcome her. Before I introduce our guest tonight, I would like to move forward and say a word of prayer to thank God for all He is doing in our lives. Heavenly Father, we come to thank you on tonight. Lord, we thank you for the opportunity to be able to come before you one more time. We thank you, Lord God, for keeping us all during the day, Lord, bringing us safely over the dangerous highways and byways. Thank you, Lord, for keeping our children, our families, our homes safe, Lord God. Lord, we pray, Jesus, for those people who are in the hospital right now, Father. Pray for those who are incarcerated, God. Pray for those, Lord God, who are going through trials. Pray for those, Lord, who are thinking about even giving up. We just thank you and we adore you. And we ask you, Father, to be in this show tonight. Blessed God, to run smoothly, and bless the information to be useful to all who tune in now and in the days and weeks to come. In Jesus' name I pray. Amen. Dr. Danielle Motley Jennings is affectionately known as Danny. She began her journey in 1999 when she attended the University of South Carolina in the College of Math and Science. There she received a bachelor's degree in biology and a research study internship in molecular biology. She was selected to attend the Medical University of South Carolina in Charleston as a minority scholar, where she completed a summer internship program for gifted students. In 2006, Jennings began her journey in doctoral school at Sherman College of Chiropractic. There, she obtained a Doctor of Chiropractic Medicine in 2010, with an emphasis in radiology. Dr. Jennings served as a clinical laboratory instructor at Remington and Virginia colleges from 2010 to 2016, where she instructed health professional students in the areas of pathology, pathophysiology, medical law, and ethics, anatomy, and physiology. Dr. Jennings has practiced with a neurologist at Midlands Neurology Pain Management and as an internist at South Carolina Physical Medicine. In 2017, Dr. Jennings opened her private practice, where she now practices full-time and serves the state of South Carolina. Her specializations include auto accident care, chiropractic care, pain management, DOT physicals, drug testing, and drug consortium. She has 3 beautiful children, a loving husband, and a puppy named Bluey. She enjoys reading good books and professional development. Without further ado, we will begin the interview And Dr. Jennings, unless there is something that you would like to add, I will move into my first question.
Hello, everyone. Mosaic Voices. How are you guys doing today? I'm so honored to be here. I forgot to mention that I was or still am a basic life support specialist, meaning that I teach CPR, and I did that for ER physicians and ICU nurses at Prisma Health during pre-COVID. So, but that was a wonderful introduction. And then at Midlands, I think it was pain management, I was not an internist. I was a doctor of chiropractic, and I practiced with an internist. So thank you so much. Glad to be here.
Thank you, Dr. Jennings, and please excuse my faux pas.
Oh.
I would like to ask you a question.
Yes,
What is
ma'am.
chiropractic medicine? Can you tell that to us who are listening?
Yes, that is a great question. So first, I'm going to give you the general definition. So chiropractic medicine, basically, the general definition that you would see on a Medicare website, you would see that we are doctors who deal with the musculoskeletal system as well as the nervous system. And we are doctors who treat as well as diagnose musculoskeletal conditions as well as neurological conditions. Now, I added the word diagnose in there. Well, I didn't add that word, it's in the definition, but I put emphasis on diagnose because in order to diagnose a condition, you have to clinically be a doctor. You have to clinically be a physician. And there's a lot of confusion out there as to what it is doctors of chiropractic do. So I do want to put that that emphasis on the word diagnose. We can actually diagnose musculoskeletal conditions as well as neurological conditions. So that's very important. But we do so, the way we treat is different from your other healthcare professionals. So doctors of chiropractic are considered whole body clinicians. That's something that's very rare out there. Your family practitioner is whole body. Your internist is whole body. Your nurse practitioner, depending on the specialty, is whole body. And your doctor of chiropractic is also whole body. So there's not too many whole body clinicians out there. But what sets us apart is that we're going to treat the condition differently, meaning without medications. So typically a doctor of chiropractic, they're going to use their hands or some type of handheld instrumentation. They also couple that with analgesic therapies that they use in the office, including laser therapies. Doctors of chiropractic can also manipulate, meaning adjust the bone under anesthesia. A lot of people don't know that. So if you go to the Labor Licensing and Review Board and you look up scope of practice for doctor of chiropractic, you will see something called MUA, which is MUA. And that is an acronym that stands for manipulation under anesthesia. So we can do that. Now, the only thing with that is you have to work closely with the anesthesiologist, and also your malpractice insurance will go up. So I don't practice with MUA, okay? My patients will go to sleep on their own on the table. I don't need anesthesia for that. So doctors of chiropractic, we use our hands. We're going to treat and diagnose musculoskeletal and neurological conditions. That's the generalized definition. Now, I want to go into a little bit more detail and talk about the infrastructure of chiropractic as well as the paradigm of chiropractic. So the infrastructure of chiropractic, it weighs heavily on something known as the three-legged stool. So you have art, you have science, and you have philosophy of chiropractic. So the science of chiropractic, this is something that most of us, at least those of us who were going into some type of pre-professional program, are used to. we are familiarized with. We had majors in biology, we had minors in chemistry, we had masters, some of us from Harvard, before going into a doctoral level program. So we knew things like pathophysiology, molecular biology. So when we took those science courses on a doctoral level that are 800 level, 700 level, you're talking about courses like gynecology, toxicology. You're talking about your laboratory diagnosis courses. You're talking about pelvic examinations, head and neck examinations. And I want to really emphasize the science that takes place in a doctoral doctor of chiropractic school, because a lot of people don't realize that. We take a lot of hours in radiology. We take a lot of hours in anatomy. We take every anatomy there is. We do spinal anatomy. We do x-ray anatomy. We do gross anatomy, where you dissect the human. And chiropractic students, we do 3 semesters of that. We're going to go into that into the next question. But they break it up for us into head and neck, thorax, and abdomen. So the point I'm trying to make is that's one component of chiropractic school. Now, had chiropractic school just been science and like other health professional schools, fine, piece of cake. But chiropractic also emphasizes on philosophy as well as art. So the art of chiropractic, now we're getting into the art of adjusting. Are you a good adjuster? Are you skillful whenever you do your manipulations? First, do no harm. That is a medical mantra. Okay, so are you doing harm to your patient? Or are you skillful? So while we're over here looking in a microscope, doing laboratory diagnosis, right? Looking at the leukocyte count, we're running over here the next hour, and we're signing up for workshops. Anybody who can help us figure out how to adjust a cuneiform bone artfully. Or we are running over here trying to figure out who can help us adjust one of the, you can see I'm passionate about this. One of the pisiform bone, or one of the carpal bones, the triquetrum. Can you help me adjust that, where I can communicate to my examiner or my superior? I'm putting a P to A force into that bone. I'm going to free up the median nerve so that this patient does not have to suffer with carpal tunnel. So not only are we dealing with the science, you also have the art. And by the way, just to put it out there, there's a lot of medical courses, okay? Some of which, some nerves and stuff I didn't even know I had in my body until I took the class. There's a lot of them. You have 206 bones in the body. You're born with 300 bones. So basically, you're born with 300 bones, they fuse, and now you're left with 206. That's a lot of bones to be artful and skillful about. That's a lot of preparation aside from your medical sciences. And we're not talking about some fly-by-night genetics course you take at the University of South Carolina. I love you, USC. We're talking about an 800 level course where the guy brings in a dialysis machine and you're studying renal physiology, and he's from Russia. Those are the type of classes I'm talking about. All right, that's the second component of the 3-legged stool. Now, don't get me started about the third leg. This is philosophy. So you enroll into a doctoral chiropractic program. They promise you that, oh, we're not like those other guys. You'll be done in 4 years. Yeah, I will be if I go year round and study not only the medical sciences and take national boards on those, but also do the other components of the 3-legged stool. Let's talk about philosophy for a second. We're not talking about philosophy where we have Plato and who else? Socrates sitting around saying, if you see me, I see you. If you don't see me, I still see you. We're talking about philosophy. You're taking 8 hours sometimes, or let's just say, I won't exaggerate too much. Let's say 2 hours of a philosophical course where you're talking about the philosophical concepts of the nerves and how the philosophy of the vertebral subluxation complex, how you can apply that to the nervous system. You have to be out of your mind. And that's why a lot of people think chiropractors are out of their mind because, you know, so that's the three-legged stool. So that's what that is the infrastructure of chiropractic. Now let's talk about the paradigm. If you could put that first slide back up. Yes, so this is a good talking point. This is known as a Merrick chart. And I love to use this Merrick chart during new patient orientation because it's very easy to understand. So here we have the spinal column. It's separated into regions. It's in beautiful colors for you. And you can see out of each vertebral segment here, you have spinal nerves coming out of each vertebral segment. So they kind of illustrate for you on the chart. So what I do is if you have a misalignment, we circle those. And if you have a misalignment, what happens is there's going to become pressure on that particular spinal nerve on that level. Those little nerves are going to an organ. You can see on that chart where they're going to. And if there's a misalignment, wherever that signal was trying to go to, it can no longer get there because there is interference. So there's an acronym known as MOPI, and MOPI stands for misalignment, occlusion, pressure, and interference. So first, there's a bony misalignment in your spinal column or in your extremities. And that bony misalignment, you may not know is present, but let's just say it stays there for a while. Pretty soon is going to cause occlusion. So that's the O. That occlusion will then cause pressure on one of the spinal nerves. And those spinal nerves now will have interference because wherever they were going, they cannot travel there anymore. That is the paradigm of chiropractic. That is how it works. So people want to know, what is a profession about? You know, what are you doing? Are you going to crack my back? We're concerned with your nervous system. We're concerned with interference because we know that pain is going to run on that nervous system track. So if I clear up the interference and we fix those bony misalignments, you're not going to be in pain anyway, you know. But in a nutshell, you have the Medicare definition of chiropractic. Don't look at the definition on Wikipedia, and because I said that, you probably will. But and then you have the more detailed the infrastructure, which is a three-legged stool. And then you have the paradigm, which is the Merrick chart. And then you have the acronym MOPI, which kind of goes into more detail and describes, you know, what it is. What is our goal here? Why go to a doctor of chiropractic? You know, so that would be my definition. Oh, there they go. Oh boy. I'm in an interview.
Was that the children?
Yes. I'm sorry.
How many times a year should a person see a chiropractor?
So unfortunately, help her out, Autumn. Unfortunately, insurance companies dictate that. People who have never gone to school dictate that. So Medicare allows people who have never gone to chiropractic school dictate that. Medicare allows 12 visits. 20 visits. If you want more than 20 visits, then your doctor of chiropractic has to get on the phone with other representatives, other doctors. You have internists, neurologists. I've done that a couple of times. And you have to do what they call a peer-to-peer review. And on that peer-to-peer review, I'm not taking you to the fair. If you don't listen, I'm not taking you to the fair. You have to do what they call a peer-to-peer review. And you have to explain, why does this patient need more visits? And I've done that several times. So Medicare is about 12, 20 visits. If you have Blue Cross Blue Shield, I've seen plans that were as high as 40 visits and as low as 22. Some plans, they give you a certain allotment So state PIBA, you get $2,000 of chiropractic for the year. I think Medicaid, you get 6 visits. I've had to do a lot of peer-to-peer reviews for Medicaid. But in my opinion, how often you should go. So research suggests that 12 visits, you will start seeing some type of change biomechanically, as well as in your nervous system. That's research, is 12 visits. And I'm going to share the site where I get all of my research from. But yeah,
Okay.
12 visits is typically what you should do. And when we have auto accident patients, we tell them your attorney has paid for 12 visits. However, if you need more time or you feel like you need more visits, let us know and we will contact your attorney and then they will give you more visits.
Okay. We know that you're a mom.
Yes.
How do you juggle being a mom and a medical entrepreneur?
I really, and I know this may sound cliche, but I really give all of that credit to God, because there was a point in my life where I was just like, I cannot do this. Like, this is just too much. I tried over and over again. The first time I opened a practice, it failed. You mentioned in my bio, the different places I've practiced at. I've traveled all across the state trying to make this work, and just learning and doing externships and things like that. It was very challenging. When I took my national board exams, I had to take them in basically sections because I was pregnant, and then I was scared after paying all that money for the exam. I said, please don't let me get baby brain. So I'm like, I paid thousands of dollars for this test. I don't need baby brain. But it was a difficult journey. How do I juggle it today? As crazy as my life may look and busy as it may look, is way better and less busy than it was a couple of years ago when I was trying to get this off the ground. So I guess to answer your question, I've just been kind of dealing with it.
Okay.
The best, that I know how.
Yes. And I really do admire you for what you do. And I admire you for your tenacity, because I know some of what you have gone through. Now, when exactly did you decide to open Premier Spinal Health? That is your business that you own today.
Yes. So I made an executive decision because I was practicing in places where if my child was sick or, I had an emergency, or even if I was sick, I was being told, you are the only provider. We have so many people in the schedule. We need you and you have to be here. So I couldn't take off. I couldn't go to games. I couldn't go to after school events with my children. I couldn't do any of those things. And I said, you know what? There has to be a way. And I thought about it. I said, well, at that time, I don't describe myself as this anymore because I've been forced to come out of my shell. But at that time, I said, I don't know if I can talk to people to even get them to come see me as a doctor. I don't know if I can even do this on my own. So it just took a lot of, things, events happening, and just pressure from work environment and things like that for me to make an executive decision and say, you know what? I've gained enough knowledge. I've practiced with enough doctors. It is now my time. Let's open up Premier Spinal Health. When I opened Premier Spinal Health in 2016, I won't say I failed, but it was not successful. And I had to go back to the drawing board, and I had marketers. Was paying astronomical prices for marketing. People who knew nothing about chiropractic or how to market, I was paying them to market for me. Yes. No, don't put that in the microwave. Use a regular plate. And when I got set up, it was one practice I went to, and they were so gracious. They got me set up on all the insurance networks because I didn't know how to do that. Apparently you had to pay a credential specialist to get you set up on stuff like that. So they were so nice to me. They got me all set up on all these different networks. And once the money started coming in, I took additional credentialing. So I'm also a medical examiner for FMCSA, which means I do the DOT physicals. And once I started doing that, I tried again. I said, okay, I'm credentialed. I have all my tools behind me now. I'm not going to give up on this. Let's try it again. So I did it again. And by the grace of God, one person walked through the door and they were very impressed. And they said, I'm going to tell everybody about you. And then someone else comes in and they said, you know what? My company needs, we're going to tell everybody. Really? This is great service. And it was just like a cascade effect. And it just, the Lord blessed me so much to the point where now I can't even keep up. And I think I spoke to you about this. It's like, I'm eventually going to need to hire another practitioner or someone in there who can assist me and help me as well. So I just decided to open Premier Spinal because I knew my worth, and I knew that I had a lot of gifts and things to give. And I wanted to do that.
Now, I want to say something here. Let me interject something for those of you who are not aware. Dr. Jennings just moved into a large office. And I know that this took a lot of prayer, a lot of seeking God, but your practice has grown to the extent that you had to do this. You have a very lucrative practice now. You want to talk about where you're located and how people can get to you?
Yes. So you can go to our website. The website is premierspinalhealth.com. We also have a Facebook page. If you're on Alpine Road, so our new office is 2711 Alpine Road. If you're in the area and you Google like chiropractors near me, we'll come up. If you Google DOT physicals near me, we should pop up. But I love the office. It's very nice. But I will say we get cursed out. I don't know if I can say that on your show, but we get cursed out at least once a week from very angry people who don't read their emails. And they tell us, we didn't know y'all moved. So it was a task. It was a task moving, but I love it. It is gorgeous. And like I told one of the patients, I said, this is because of you. You know what I mean? You all were able to help me do this. I didn't do this. This is because of you. And we just want to get something that was more accommodating for the patients. Yes.
Well, that is really, I give all glory to God. And it is also a testimony to you as a young woman who I know what you went through. I know what you went through in school. I know what you have gone through professionally. And to have the tenacity to stick with it, not just stick with it, but to grow it as a young Black woman, to me, that is extraordinary. And as a wife and mother, because I understand what obstacles you have faced. Now, I want to ask you a question. When you adjust a patient, how do you know what you're touching to make that adjustment?
Okay, that's a very good question. We actually get asked that question at least one time a week. So, doctors at chiropractic, we're very good at anatomy. And when the patient is lying down on the table or they're sitting up in the chair and you're about to make that adjustment, we're not looking at the patient. We're kind of seeing the anatomy through space. And so we learn a lot of what we call anatomical markers. So to kind of give you an idea, you feel the base of the skull, which is here. The very first bump you feel is going to be C2 spinous process, because C1 doesn't have a spinous process. It has a posterior tubercle. So little things like that we learn in school. When you travel on down the spine, when the patient at the level of the inferior angle of the scapula, that's going to be the T6, T7 region. So when you go here to the hip bone or to the ilia, I like to always palpate, especially female SI joints, which are the sacroiliac joints, because females, what do? We carry most of our weight on our bottom. So they're going to have inflamed SI joints. I mean, that's just a given for most females. So I always palpate the SI joints, and then my patients are like, how did you know that was bothering me? And I'm thinking to myself, you're a female and these are your SI joints. And then when you go up a little bit, you can feel the crest of the ilium. It's two little bumps there, and we call those the PSISs, or posterior superior iliac spines. You can tell if one has rocked up or has rotated, and that's really that's what we're doing. We're feeling anatomical markers to see where we are in space, where we are on the patient, and we confirm that through restriction motion techniques in orthopedic testing, because that will also isolate those joints. So there's a lot that goes into that. The patient thinks that we're just giving them a nice little pat down, but that's not what we're doing. We're all the stuff is in here, and we're kind of feeling those anatomical markers and doing the restriction and making those adjustments that way. So yeah, we definitely get asked that question. But most of what we do is through touch. And also, I know a lot of patients also ask me, well, can I let my 2-year-old or a 5-year-old walk on my back? And my answer is no. And I don't let my children come anywhere near my neck or back. But the reason being is, I don't know if you can see this, but the features of the vertebrae, they change as you travel down the spine. They're changing. So when you get to the lumbar spine, this isn't connected anymore like it was here. So if you let someone walk on your back down here, you may hear a nice little audible or a nice little pop, but these two aren't really connected the way they are up here, and you don't want anything to go wrong. And these easily do break off in the lumbar spine. Mm-hmm. But that's how you know.
Okay, I am going to go through a few conditions, and I know that I'm going to mess the names up because I'm not a doctor.
Okay.
And I'd like for you to tell us a little bit about them and what a patient can do to improve their outlook. We have about 25 or so minutes left. I can say rheumatoid arthritis because I'm familiar with that. So talk about rheumatoid arthritis.
Okay, so rheumatoid arthritis, this is known as RA, is going to affect mostly females. Mostly females. And every single time I say that, there is someone that tell me, well, I know someone who's a male who had it. Mostly females, okay? They do. Rheumatoid arthritis, listen to this, is autoimmune. So that means your immune system has a lot to do with this condition. Now, they do say the predilection is based upon like smokers or, there's other risk factors that people may have. But autoimmune, it affects women, and it affects, usually you're going to be diagnosed with this in your younger years. So this is not like an elderly type of arthritis. Mm-hmm. And you can see this is the most crippling type of arthritis because you can see the hands deform. This is going to affect your more peripheral joints. So let's talk about the cracking of the knuckles, because people come in the office and they say, can I crack my knuckles? When you crack my back, are you cracking my, is it like me doing this? No, because no, this is what they ask. They ask, can they get arthritis from cracking their knuckles? I'm sorry. That's what they ask. Can I get arthritis if I crack my knuckles? No, because the only type of arthritis that's going to affect your peripheral joints, which are these, are going to be rheumatoid arthritis, psoriatic arthritis. Those usually affect the more peripheral joints. Okay. So that is a classic hand sign. And you see how the metacarpals look there, the fingers and the thumb. The feet also do that because they're peripheral. And when I used to teach, I think it was pathophysiology or something, some class. I showed the students a video, and this lady, I mean, this is crippling. This is debilitating. RA, you have to take medications. It's very crippling. And it was in her toes to the point where she could not walk, and she had to get surgery. I believe the podiatrist gave her surgery. And so yeah, it affects the peripheral joints. It is predilection of female. It is younger female population, and it is autoimmune.
Okay. Now I have osteoarthritis. Talk to us a little bit about osteoarthritis.
Okay, so osteoarthritis, that is known as OA. And osteoarthritis, a telltale sign of that, is going to affect the weight-bearing joints. So we're talking your hips, your knees, and your ankle. So that's the difference between the peripheral joints and your weight-bearing joints. So if you see the figure B here, and you see how one knee joint, you can clearly see the spaces. But in the other knee joint, you can see that one of the spaces are not as prevalent. A telltale sign of OA is something called unilateral loss of joint space. Unilateral is not going to be bilateral, which means both knee joints will not be closed down, only one. And I'm not talking about the left knee compared to the right knee. I'm talking about the spaces on that same knee. So you take one knee, the left side of that one knee is closed down, the right side is open. That's a unilateral distribution of degeneration. That is a classic sign of osteoarthritis. Another classic sign is that it's affecting the weight-bearing joints. So your hips, your knees, and your ankle. This type of arthritis is going to affect the elderly more, unless you are an athlete. If you are an athlete, then you will have OA. And I've seen people who are very young, but they were very athletic, and now they do have arthritis in their weight-bearing joints. So that is a classic sign of OA. I'm trying to see what else I can point out here. I believe that unilateral distribution loss of joint space, that is just a telltale sign there.
All right. What is scoliosis?
Scoliosis is a curvature condition. This is a condition that most people have heard of before when it comes to musculoskeletal. Everyone has heard of scoliosis, but they may not know exactly what it is. So scoliosis is just a curvature of the spinal column. And don't let this picture fool you. They say a picture is worth 1,000 words. There are 300 different classifications of scoliosis, and it's all classified based upon the rotation of the vertebra.
Wow.
So here you can, and it's also based upon which side the concave side is on. So it's a lot of detail when you're diagnosing scoliosis. You can see here, the concave side is on my right, The convex side is on the left, which means the rotation is going towards the convex side. So this would be classified as a rotatory type of scoliosis. Yes, you can treat this through manipulation, but the degree of rotation must be measured on a radiograph or an x-ray in order for you to be able to say, should I refer this patient to an orthopedist, or should I retain this patient and do manipulation? So when we do the x-ray, or let's say like we outsource our x-rays. So if I send someone to Palmetto Imaging, the radiologists, they're not going to draw lines for me on an x-ray. I have to do that myself. But they will give me their impression. It's called an impression of the radiologist. And they will put in there the degree of rotation. And if it's more than 18 degrees, they have to be braced. If it's less than 18 degrees, they may have a chance. So that's the degree. It's 18 degrees. Scoliosis can affect your internal anatomy. It can. So it can start playing with your heart, your lungs, because there's a curvature there, and the organs will also shift, because we know most of your organs are in the abdominal pelvic cavity, or the abdominal cavity, or thoracic cavity. And so usually most scoliosis will be more prevalent in the thoracic spine. I have seen some in the lumbar spine as well, but most would be more prevalent in the thoracic spine. Luckily, we have the ribs there in the thoracic spine to protect us. That's the way we were made. And to protect the anatomy there, because that's where most of your vital organs are. So we have ribs there to protect us, but those little rib heads can pop in and out too. And we adjust those ribs, because if your rib head comes out, then you will have difficulty breathing. And a lot of people, if you ever had a fractured rib, you can't breathe with it. You can't breathe with it. And it's extremely painful.
Yes.
So if it's not a fractured rib, but the rib has popped out and you're having shortness of breath, we can pop that back in for you. So there's little costal facets on the sides, on the lateral sides of the vertebrae in the thoracic region, and they move. They can come in and out. And you can see with the curvature there, that is a possibility for that patient.
Okay, I'm gonna go skip some, because I want to try to get as much in as we can before we run out of time. So I'm going down to abdominal aortic aneurysm. Also, there's some I can't say, and I'm not going to embarrass myself by trying. Abdominal aortic aneurysm. What is that?
I won't judge you, I promise. So a AAA, I call that a AAA. So you guys know what an aorta is. That aorta from the heart, when you hear aorta, you think about the heart. That's where it's coming from. The aorta travels down your body, and it bifurcates, meaning it splits into two iliac arteries going into the legs. But before it splits, when it goes into the region of the abdomen, is known as the abdominal aorta, because it's in that region. Now, if you have a lot of calcification and you come to us, we take an x-ray, I just want to put this out there. When we take your image, we can see if you have cancer, because most cancers, because cancer is going to metastasize to bone. So the image will be bright white or very lytic. Here, the image is lytic. You can see that lytic lucency in the anterior part of the abdomen that's traveling down. And we know that that aorta is something going on there. So we're going back to allowing someone to walk on your back. So you go to your friend's house and you say, Susan, I'm having back pain. I don't feel like going to the doctor today. Can you just kind of walk on my back? She doesn't know she has a AAA. And she doesn't know the AAA is referring pain to her back. So she lets Susan walk on her back. And now the aneurysm ruptures.
God.
And now she is either paralytic, or she is unresponsive, or she needs to be
God.
rushed. Hopefully, Susan knows CPR and can revive her until the ambulance gets there. So the difference between a doctor of chiropractic and Susan is that we know when to adjust, but we also know when not to.
Mhm.
And the way we know when not, the reason we know when not to, or how we know when not to, is because of all these medical sciences we took and all these crazy sounding conditions that we had to take national board exams for, because they had enough sense to know you need to be able to refer these people out and outsource them if something like this pops up on the image. It's getting so bad to the point where if I do take x-rays, I put filtration over the lead vest over the lung fields, because if I take an image and I see you have alveolar edema, I see you have pneumonia, but I don't refer you to the hospital, and I say, well, I'm just going to focus on the spine, and that has happened, I will be held liable for that.
Mhm. Mhm.
And they'll say, well, Dr. Jennings, why didn't you refer this patient out? You can clearly see that the lung fields are filled full of fluid. You can see here she has alveolar edema. Why didn't you refer her to a primary doctor or to some type of, so I cover that up because I don't want to be held liable. But here, you can't cover that up. That's right anterior to the abdomen. And that is a medical emergency. That is called a AAA.
Wow.
And we see all kind of stuff on x-ray. Even though we're just looking for the spine, a lot of stuff travels to the spine. There's a lot of bony tumors,
Mm.
all type of tumors we see. One time I was treating a patient. She kept complaining of her shoulder hurt. Her shoulder was hurting her. Her shoulder was hurting her. I said, well, I'm the type of doctor, if you tell me something more than once, even though the facts aren't there, I'm going to listen to you because that's your body. That's not my body. She said the pain was excruciating. I said, you need to have an MRI. At the time, the practice I was at was owned by two non-doctors. They told me she will not get an MRI because if she gets an MRI, we will not be able to retain that patient and we will have to refer that patient out and we will lose money. I said, she needs an MRI and she needs one today. The radiologist called me and asked to speak with me personally. He never does this. Never. He said, Dr. Jennings. I said, hello, how are you? He says, she has, and it was a cancer. I won't say it online. It was a type of cancer. And it had metastasized to her shoulder. I don't know if I saved that lady's life. But then the radiologist had the nerve to tell me, you need to send her to an oncologist. I said, sir, isn't that your job? You took the image. So that's what we did. She went to an oncologist. I don't, shortly after I left the practice, so I don't know what happened to her. But I'm glad that we were able to be thorough and to listen and to see what was actually the cause of her shoulder pain.
Yes. I do know that you're going to be getting an x-ray machine in the near future. Am I correct?
Digital x-ray. It is digital. And right now we're just we have to meet with the physicist to make sure that everything is, the way it should be before we start shooting all those electrons everywhere. But yes, we are definitely, it's on the way and we are so excited about that. But everyone's moving to digital now. I've been in dark rooms. I've been where you had to do the red light thing. I hated it. I've also been in practices that did digital. Digital, the image comes up. We can email you the image. We can send the image to a referral. It's just a lot more accommodating for us and for the patient.
Well, we're almost out of time, but I'd like to say this. I can remember going to rehab, and they weren't doing anything for me. They were pumping me full of medication. I was doing all of these exercises and I wasn't getting any better. Well, because I'm a senior citizen, I'm on Medicare, and there were so many visits that they wanted me to come to. You remember we had this conversation, and every time they would ask me, "Are you any better?" I would say no, because I wasn't. And I remember when I came to you. When I came to you and you adjusted me for the first time in, like, I don't know, I'd already had almost all my visits. I was pain free. And I went back to my doctor at the time and I told him, I said, "You all don't know what you're doing." I said, "You should send patients to Dr. Jennings because I was in a lot of pain and she helped me and I don't have that pain." Now, you told me I shouldn't have said that, but hey, at my age, I don't worry about things like that. But people need to know that they can spend a whole lot of money taking medicine. Medicine is good, but medicine just helps you. It tells the brain you don't have pain. And so the pain is masked sometimes. And I don't want to put you on the spot by asking you to respond to that, but that's a true story. And I haven't been back to any of those, and that was over a year ago. I refused to go back. And then I went to an orthopedic doctor who wanted to start injecting me in my knees. And I told him no. I told him no. So in coming to you, it has helped me avoid a lot of drugs. Go ahead.
Okay. So first, I will say that you do have doctors of chiropractic that prescribe. They are called advanced doctors of chiropractic medicine. It's something Medicare has started, or they're in the middle of it, and they're trying to move it for all 50 states. Right now, that's not the case for all 50 states, but they're trying to move it there. And they also are trying to push chiropractors to the front line to be primary physicians for musculoskeletal only. So doctors' cares and especially with auto accident patients, they will always refer. If you go to doctor's care first, they're referring to us now. So a lot of people walk in the door and they say, "We came from doctor's care. They told me to go see a chiropractor." That's how we get a lot of patients. As far as physical therapy, I will say that physical therapy is active, meaning you are doing something. They are training you to rework those joints, rework those muscles. Chiropractic is passive, meaning we're doing everything for you. We're moving, we're manipulating for you, we're doing the therapies for you. That is the difference. And also the fact that physical therapists cannot manipulate. We do. So there is a difference there. And I'm glad that you saw a change in that joint, because I remember, how much and how to the severity, to the point where like you need an MRI because it was just severe. And so I'm glad that it all worked out for you. But these are the story you told and you just shared. This is something I hear on a daily basis. And I'm sure other healthcare professionals, they hear bad stuff about us too on a daily basis. It's, but yeah.
Now I'm going to say this, and we're about at the closing period, and then I'll give you the final remarks. I remember I came to you for my sciatic nerve. And you were a student at Sherman. I drove all the way to Spartanburg. And you began treating me in Spartanburg. My sciatic nerve was extremely painful, and I had to walk up with a cane. Remember that?
I do.
And being treated, thank God, I haven't walked with a cane in over 10 years because you treated me for sciatica. So you want to, I know we only like 2 minutes or so away, but can you talk a little bit about that sciatic nerve? Because that's extremely painful.
There's different levels and degrees of sciatica. And this is what people don't realize. It can be so bad to the point where you can't walk, or you can be at the beginning stages where it's just starting to bother you a little bit. Usually the treatment for that is some type of injection, and then they give you NSAID, and then they also give you something like a pain medication and anti-inflammatory. Chiropractic, usually, so the sciatic nerve is the largest nerve in the body. And what happens is it has to travel through the pelvic bone. This pelvic bone can move. So sometimes when it moves out of position, it starts pressing on that sciatic nerve, and it's going to send shooting pain down the thigh into the foot. So as chiropractors, what we do is we free up that pelvis.
Yeah.
And that allows freedom for that sciatic nerve so that there's no more pressure on it. So pregnant women, they get sciatica. Male patients who sit on their wallets, they get sciatica. Don't sit on your wallet. And what we do is we move that pelvic bone, and it's going to free up that nerve. And you know, people are just, they're so amazed whenever like their nerve pain goes away down their arm, but it's really just simple biomechanics and anatomy that I was explaining earlier. Mm-hmm. Is really all it is. But yeah, that's why didn't I put sciatica on the question?
Sciatica is on what I have. I don't know why you didn't have it.
Yeah, that's a common one.
One last thing, and we're going to go a little bit over, but one last thing is bursitis. A lot of people have.
Yes, bursitis. Oh my gosh. I can tell you countless stories about bursitis. So the bursa are little sacs. They're fluid-filled sacs, and they're found in the shoulders. They're found in the hips. And so you have different types of bursitis. So you have bacterial, which would be a medical emergency. You can't go to a chiropractor and it's bacterial and expect us to do something about that. You need to get that aspirated. Or it can be biomechanical, which just means the bony anatomy is encroaching on the bursa, the sac. So the doctor of chiropractic's job, if you come to us first, our job is to tell the difference. Is it bacterial or is it biomechanical? And there's orthopedic tests to do that. If it's bacterial, we send you out. I had a patient who had bursitis, and she visited a chiropractor previously. I practiced at Palmetto Physical Medicine, and that's the way I knew this was bursitis, because I remember another patient there had it. So she came to see us, and she said, well, I went to the chiropractor, and he told me it was the pain is not bursitis, it's coming from my lower back. So we did the x-rays, we did the palpation, we did the orthopedic test. Everything was just honing in on that bursa. I said, I really think this is bursitis. I'm not thinking this is the lumbar spine. And she said, well, I mean, he told me it was my lower back. I said, why don't we do this? Why don't we send you out and we get a second opinion and we get it diagnosed? And the reason why I sent her out was because I wanted to decipher between bacterial and biomechanical. Sure enough, it was bursitis. She came to me, she said, young lady, she said, I've been to so many different doctors, and she said, I just left a chiropractor. And she said, you told me it was bursitis. And I remember that because the pain is a little different with bursitis. It's a little different. Usually if it's lumbopelvic pain that's radiating, it's going to go down the back of your leg unless there's like an impinged disc. But her pain was more on the lateral side, right where that bursa was. And there's orthopedic tests you can do to test the bursa. So
Mhm.
I don't know, maybe I have too much time in my office and I'm doing too many tests. But yeah, that's a big one. A lot of people have bursitis. And if you're a weightlifter, you might get bursitis and you might get a torn muscle. We get a lot of weightlifters who come into the office. And the first thing they ask me is, well, can I still lift?
Wow.
I mean, I don't know what to tell them.
Well, I can tell you what, I can't help you because I can't pronounce half of these words on the screen. So I kind of jumped through to the ones that I knew I wouldn't mess up too badly. Dr. Jennings, thank you so much for being on our Mosaic Voices from the Community. And we're going to have you back again because it's a lot of stuff here that we just did not have time for you to go through. And I commend you because I could hear the kids in the background. Mommy didn't skip a beat. So
Mommy gave some looks though. I was like, come on,
oh
now.
my God. I tell you what, I know my grandbabies, and I know good and well, you're a good mom. And I want to thank you so much. Now I'm going to give you final remarks, and then we'll go ahead and close out.
Okay, so this month is Chiropractic Awareness Month.
Yes.
We're doing some great things at the office if you guys stop by. And one of the things is we have questions that the patients submitted. And I know a lot of them were asking questions because we told them that they would get either a gas card or we are giving out a $650 spa package. This spa package, you can get Botox, you can get lipo, anything you want. Those are my good friends over there at that medical spa. So can I read some questions?
Yes, but
Time.
this is being pre-recorded, so
That's
I
okay.
don't know how they will get the answers to you because when they see it, it's not going to be live.
No, I'm going to read the questions and answer their questions.
Oh, yes.
We're going to watch it.
Yes.
All right. See, I knew it. Now, this young lady who submitted this question, she works with me. And she says, can cracking your fingers cause arthritis? So I already answered that question. The answer is no. All right, this question, how many bones are in the body? I also answered that. 206 adult, and then you're born with 300 bones. This is a pastor, Pastor Keith. How long does it take to start noticing results? Oh God, Pastor Keith. It depends on the patient, Pastor Keith. It depends on the patient. And if you're compliant, Pastor Keith.
Tell them to pray about it.
Exactly. Okay. Can Chiro help people be able to walk again? I mean, I've heard so many like riveting stories. I don't personally know the research on that. And then one story I saw on a feed, it was about a chiropractor who helped a young boy be able to walk again. And then, an orthopedic surgeon and someone else chimed in and was like, that's ridiculous. It's just muscle spasms. So, I mean, yeah, you got to know the anatomy. Let's see. What does this one say? What is the little object you use called the activator used for? Okay.
I love that.
This is an activator instrument. This is used to adjust. This is not a needle. I'm not going to inject you with anything, I promise. This goes to the bone and it moves the bone. We use this on elderly and we use this on babies. If you don't like the audible, if you don't like to hear, bones and stuff, then you would want to use this. And I have a lot of patients who come in and they say, do you use activator? And I say, yes. You will not hurt my feelings, I promise you, because if I adjust you manually, I am using up my joints and, having to hold your head and all kind of stuff. I prefer this, but you have those who they want to hear it. So, but this is an activator. It don't let it fool you. If I had a styrofoam cup and I did this, it would shoot across the room. So they come in different classes. This is, I believe, a class 2 activator, but they can become very pricey. The next question. How old do you have to be in order to receive chiropractic treatment? That's an excellent question. And that question comes from Ms. Crystal DeBerry. Very good question. So infants can receive chiropractic care. And the only time you will see a doctor of chiropractic in the hospital is they have hospital privileges. You have pediatric chiropractors who have hospital privileges. They're there when the baby is born and they do the adjustment. Why? Because when the baby comes through the birth canal, what happens? The doctor does this to get the baby out. So the ligaments in the neck can become compromised, and there's a whole other discipline that deals with nothing but pediatric adjusting, and that's what they do. They have hospital privileges. They go to the hospital, they're there, and they help the mother throughout birth, and then they adjust the baby. So yes, infant, you can do infant. And usually the fingers are used. We don't even use this on infants. It's just light touches. We answered that one. Can chiro help with patients who have arthritis? How does it affect pregnancy? So I kind of just talked about that. I was adjusted with Autumn, but not with Gabby. And I saw a huge difference in the two as far as my symptoms. So anytime the abdominal region increases, the lower back pain will increase. So that's why people with larger abdominal areas, they tend to have back pain. And when they go to the doctor, it's like, what does your primary doctor tell you? Well, you need to lose some weight. Okay, he's right. I mean, the delivery wasn't right, but he's right, because when your abdominal area increases, the lordosis increases, and then it's going to put pressure on your back, and then that's how you get a spondylolisthesis. Y'all, I could talk to y'all about this for hours.
Well, we're going to have to go ahead because we're 10 minutes over
Okay.
our time, and we're going to have to get you to come back. We're going to have to get you to come back and do a part 2 to this, because like I said, it's so much that we didn't go over.
It's a lot.
And I'm sure that people have other questions that they would like to ask. And one thing that I'd like to say, during COVID, you were a chiropractor in Prisma Health.
Mm-hmm.
And I didn't see that on your introduction. But
I left. I don't know why I left that part out.
Yeah. So we have to talk a little bit when we come back about your experience working as a chiropractor with COVID patients. But at this time, we're going to go ahead. And Dr. Jennings, thank you so very much for your time and sacrificing the time to come here. And like I said, we are going to have you back. We'll do a part 2 to this. And at that point, we're going to go ahead and close the show. And again, everyone, thank you so much for your patience and attention to this show.